Acute coronary syndrome. Now this is the next of the last time we discussed the chronic stable angina, which is one of the variants of this ischemic heart disease. Now we discuss acute coronary syndrome. Now acute coronary syndrome is a very labile condition. What happens when you have got atherosclerotic cardiovascular disease, you got an atheroma here going on, which is encroaching on the coronary lumen and compromising the blood supply. But as the disease progresses, at some point in the disease process, the overlying intima becomes abnormal. There is break in the intimal lining, and then you see platelets deposit over the exposed collagen tissue beneath the intima, and this coagulation process starts. There is a platelet plug which is formed, and over that clotting factors, they start accumulating. And depending upon the balance between the procoagulant and anticoagulant state, the increase in size may remain there or may sometimes disappear. So this is what causes an acute obstruction to the coronary circulation, and the patient has one of these. Is either unstable angina. Unstable angina means that the lumen is very compromised, the patient is having symptoms of minimal activity, but still there is no myocardial necrosis. But this can progress to non-ST elevation MI or ST elevation MI. The NSTEMI means that the full thickness of the myocardium is not damaged, while in STEMI the full thickness of myocardium is damaged. So patient may have one of these. So today we are going to discuss non-ST elevation MI. Now see the clinical features. Clinical features are the same as we discussed in chronic stable angina. The patient has chest pain. But you see the chest pain is slightly more severe than the chest pain which is seen in angina. Another important feature is that this pain may come on rest. In chronic stable angina, the pain usually comes with activity or maneuvers which increase the heart rate. For example, exercise or excitement or taking a heavy meal or extremes of weather, they can produce vasoconstriction, and patient has tachycardia and the pain is precipitated. But this pain, although very similar in character to the pain of chronic stable angina, but usually tends to come on rest, is more severe. And again, it may radiate to the same areas. It may radiate up into the throat, into the jaw, into the left arm, left shoulder, maybe right shoulder, into the epigastrium or into the interscapular region. So you see the pain has similar character and similar distribution. But the important feature is this pain may come on rest, and the pain is slightly more severe, and it has a longer duration than chronic stable angina, and it does not improve on sitting, and it may somewhat improve on sublingual nitrates, but it generally tends to persist. Some of the patient may develop shortness of breath along with the pain, and patient may have features of autonomic stimulation. Patient may have nausea and vomiting, and there may be cold perspiration, which we call diaphoresis. The patient may have these symptoms. And another important feature of infarction, which differentiates it from angina, is that feeling of impending doom. The patient complains, as I feel as if I'm dying. So there is something very serious going on. So this is also called anger anemi. So this is an important feature. If a patient has developed myocardial infarction, especially the STEMI, the patient has this feeling of impending doom. You see, now 1/3 of the patients may not present with chest pain. That is a little difficult to pick. Patients who've got extreme old age, those who are diabetics, and sometimes in females, they don't have chest pain. So this is called painless myocardial infarction. This is not asymptomatic myocardial infarction. Symptom may be present in other form. For example, patient may present with feeling of suffocation, patient may present with nausea, or patient may present with the restlessness, and patient may even present with syncope. So you see 1/3 of the patient may not complain of pain, but if the symptoms are suggestive and the patient has a background risk factors, then you should consider in those patients that there may be an ischemic heart disease going on. And 10% of the patient, they present with the features of heart failure. There is tachycardia, there is galloping heart rate. You may find crepitation. The patient complains of shortness of breath and orthopnea. Now, when we investigate these patients, The first investigation is the ECG. ECG may show ST segment depression. It may show T-wave flattening or T-wave inversion. Sometimes when patients have extensive infarction, there may be ST elevation. But you see, as I already mentioned, we will discuss it separately, the ST elevation MI. So in this section, we are going to discuss only non-ST elevation MI. So ECG non-ST elevation MI shows T-wave inversion or T-wave flattening, and there may be ST segment depression. Another important thing is that if you monitor this patient and if there is a dynamic change in ST segment and T waves, this is very, very significant. So when a patient lands in the emergency room with this chest pain, a lot of hospitals have a triage room in which they monitor the patient for next maybe 12 hours or 24 hours. And if the ECG does not evolve and if there are no features of myocardial necrosis, this patient may be discharged. But if the patient has this STT changes or if the patient has evidence of myocardial necrosis, patient has to be admitted. The other test which we do is for testing the myocardial necrosis. There are many tests which can be done. For example, you can check for myoglobin, you can check for creatinine kinase, the MB fraction, and you can use the cardiac troponins. You can use the other enzymes like SGOT, like lactate dehydrogenase. But these enzymes are no longer tested because the information which we want for the confirmation of diagnosis is provided by this creatinine kinase and the troponin T and troponin I. These cardiac troponins give us information whether there is myocardial necrosis or not. Now, if we find out that this patient has an MI, now what we do, what's the treatment? There are certain general measures and then there are specific measures. General measures are, number one, patient should have a bed rest. Number two, an IV line should be secured. Patient should be given supplemental oxygen. Anxiolytic in the form of diazepam may help the patient improve the anxiety, and when the anxiety improves, the cardiac demand also decreases, so it may be beneficial. And patient requires a regular monitoring of the vitals. And ECG, regular ECG monitoring may also be beneficial if this patient is having continuous symptoms. Now the specific measures. First thing is aspirin. Give the patient aspirin. Patient should chew it and swallow it. And if there is intolerance to aspirin or allergy to aspirin, if it is known, that patient can be substituted with clopidogrel. But the first drug is aspirin. If the patient is intolerant to aspirin, clopidogrel can be added. And then you can decide patient has to be managed conservatively or patient has to go on invasive procedure. Now we will see in the end what are the indications for this invasive procedure. So we decide whether the patient is to be managed conservatively or patient has to be given percutaneous intervention. Now the patients who are managed conservatively, they are put on anticoagulation, enoxaparin or fondaparinux. These are the drugs which can be used as anticoagulants. The unfractionated heparin is not preferred. These enoxaparin or fondaparinux are preferred over this unfractionated heparin. And the patient then continued on aspirin or clopidogrel. And if you go for an invasive option, so we go for an anticoagulation. Anticoagulation with enoxaparin or bivaluridine is the drug of choice. So we can put patient on these two drugs if we are planning for invasive investigation, invasive treatment. And when we plan angiography, we add a second antiplatelet before the angiography. So this may be clopidogrel or this may be glycoprotein 2B3A inhibitors like tirofiban. So these drugs can be started before the angiography, and then we do an angiography and decide what would be the course of action. The angiogram, the actual picture of angiogram tells us whether the patient is going to have a cabbage or patient is going to have a percutaneous intervention like in the form of angioplasty and a stent placement, or the patient should be managed on medical treatment. If the patient has to be treated with the coronary artery bypass grafting, the patient can be shifted to theatre, and depending upon the circumstances, a cabbage can be arranged. And if the patient has to be put on medical treatment, these antiplatelets The second antiplatelets which we added can be removed and the patient can be put on the subsequent follow-up treatment. And if the patient has to be, PCI has to be done, if already antiplatelet, second antiplatelet has not been added, you do an angiography and add second antiplatelet drugs, and in which you can also add either clopidogrel or prasugrel. So this is our course when we do. And now about the routine drugs, glycerol trinitrate, that can be used because this drug, when the patient comes in, patient has pain, the pain can be improved with glycerol nitrate. Similarly, we can use the narcotic analgesics, especially morphine, if the patient is having severe pain, or if the patient's pain is not improving with conservative measures, or if the patient has heart failure. A little bit of morphine can be added that can improve the patient's heart failure and improves the pain as well. In addition, the morphine also improves the anxiety. The patients can be put on beta blockers, calcium channel blockers, and statins for further follow-up and management. And now we see what are the patients in which we have to give invasive treatment. The indications for invasive treatment. You see, patients who've got recurrent angina with low level activity, that the quality of life is quite compromised, a little bit of activity provokes symptoms. These patients are, when they present with ACS, it's a class 1 indication that they should go for invasive treatment. Patients who've got high troponin or those who've got ST segment depression, it's a good choice that the patient should go for a primary PCI or primary angiography, and then we decide what to do. Patients who got ischemia, which is present with heart failure, or if they have a low ejection fraction, that is, ejection fraction is less than 40, these patients are good candidates for percutaneous intervention. Patients who are hemodynamically unstable, so, these patients should again be put to angiography, and depending upon the results of angiography, the treatment should be planned. Patient who got sustained ventricular tachycardia, patient who had PCI in the last 6 months, or the patient who had a prior cabbage, if they present with non-ST elevation MI or unstable angina, these are the candidates where angiography should be done, and the further course should be decided on the picture of the angiogram. And then you got, these are the class 2 and class 3 indications, the patients who got repeat presentation despite acute coronary syndrome treatment. The patients have come with acute coronary syndrome, they have been managed conservatively, and then they present again in a short interval of time. These patients are in which we should go for invasive treatment options. Patients who got extensive comorbidities, for example, patients have diabetes, patient may have kidney disease, patient may have strokes or other things. If they have a favorable risk-benefit ratio, if they do not, for example, if the kidney function is not that much compromised, creatinine is not that high, and they have got grade 1 or grade 2 kidney disease, they are good candidates that they should undergo the invasive management. So these are the different management policies in non-ST elevation and MI. Next time we are going to discuss the ST elevation MI, which has slightly different treatment algorithms than non-ST elevation MI.